Find out the two crucial clues that reveal a hidden cause of sudden severe hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-certified nephrologist, certified hypertension specialist, internal medicine specialist. See video description for disclosures. A 77-year-old man with chronic kidney disease and hypertension is referred after several secondary hypertension evaluations failed to explain an abrupt loss of blood pressure control. He has a remote history of nephrolithiasis and underwent cholecystectomy in his 50s. He also has chronic spontaneous urticaria, atrial fibrillation, and dyslipidemia. He does not use illicit drugs, nonsteroidal anti-inflammatory drugs, sympathomimetics, or herbal preparations. Pollen causes rhinorrhea. His family has no history of endocrine hypertension or premature stroke. His medications are warfarin adjusted to the international normalized ratio, carvedilol 25 mg twice daily, amlodipine 10 mg daily, hydralazine 50 mg 3 times daily, furosemide 40 mg daily, atorvastatin 40 mg nightly, and cetirizine 10 mg daily. Warfarin was held before and restarted after an ultrasound-guided left native kidney biopsy 3 weeks ago. The biopsy followed progressive proteinuria. Light microscopy showed chronic vascular and tubulointerstitial scarring without immune complex disease. During the following 2 weeks, he developed left flank pressure, early satiety, reduced urine output, and systolic readings above 200 millimeters of mercury. He denies diaphoresis, tremor, flushing, licorice ingestion, decongestant use, and medication non-adherence. Blood pressure is 214 over 118 millimeters of mercury in both arms. Pulse is 66 beats per minute. Temperature is 36.2 degrees Celsius. Respiratory rate is 18 breaths per minute. And oxygen saturation is 96% on room air. Examination shows left flank fullness and tenderness, retinal arteriolar narrowing, and arteriovenous nicking consistent with mild hypertensive retinopathy in the Mitchell-Wong schema, and legacy Keith-Wagoner-Barker grade 2, a soft abdominal brute, and bilateral ankle edema. There is no pulse deficit, Cushingoid appearance, palpable abdominal mass, urticarial flare, or right upper quadrant tenderness. Estimated glomerular filtration rate has fallen from 43 to 31 milliliters per minute per 1.73 square meters, normal at least 60 milliliters per minute per 1.73 square meters. Hemoglobin has fallen from 12.8 to 9.8 grams per deciliter, normal 13.5 to 17.5 grams per deciliter. Potassium is 3.2 milliequivalents per liter, normal 3.5 to 5.0 milliequivalents per liter. Plasma renin activity is 18 nanograms per milliliter per hour, normal upright range 0.6 to 4.3 nanograms per milliliter per hour, and aldosterone is 14 nanograms per deciliter, normal upright range 4 to 31 nanograms per deciliter. Urinalysis shows 12 red blood cells per high-power field, normal 0 to 2 per high-power field. A focused renal artery duplex study, technically limited by poor acoustic windows, shows no osteostenosis, but demonstrates markedly reduced end-diastolic flow and an elevated resistive index in the left kidney. The perirenal soft tissues are incompletely visualized. Nuclear renography shows delayed left cortical uptake without urinary obstruction. A head-computed tomography obtained after a fall showed no acute intracranial abnormality, and prior right upper quadrant ultrasonography for episodic postprandial discomfort showed no biliary ductal dilation in a post-cholecystectomy abdomen. Which next diagnostic study most directly resolves the cause missed by the standard secondary hypertension evaluation? Option A. Obtain Group 2 gadolinium-enhanced renal magnetic resonance angiography to evaluate renal arterial inflow, venous patency, and asymmetric cortical perfusion. Option B. Repeat captopril-enhanced nuclear renography to quantify interval changes in differential cortical uptake and excretory function after renin-angiotensin system blockade. Option C. Obtain urgent non-contrast computed tomography of the abdomen, including both kidneys, to characterize a subcapsular collection and quantify its mass effect on the left kidney. Option D. Obtain multiphase computed tomographic renal angiography to identify a segmental arterial pseudoaneurysm active extravasation or occult renal artery stenosis. The correct answer is option C. Obtain urgent non-contrast computed tomography of the abdomen, including both kidneys, to characterize a subcapsular collection and quantify its mass effect on the left kidney. The abrupt hypertension began after a left native kidney biopsy and is accompanied by left flank fullness, early satiety, falling hemoglobin, declining kidney function, hematuria, and markedly elevated plasma renin activity. Reduced end-diastolic flow and an elevated intrarenal resistive index on the left indicate external parenchymal compression rather than an isolated osteostenosis. This is the classic physiology of Page kidney, most likely caused by a post-biopsy subcapsular hematoma. Urgent non-contrast abdominal computed tomography can directly demonstrate a high attenuation subcapsular collection, define its size, and quantify compression of the left kidney without additional contrast exposure. Multi-phase computed tomographic angiography would be appropriate if active arterial bleeding, pseudoaneurysm, or another vascular lesion remained the leading concern, but the central unanswered question is whether a compressive subcapsular collection is present. Magnetic resonance angiography primarily assesses arterial inflow, venous patency, and perfusion. It is less direct and slower for characterizing an acute or subacute blood collection. Repeating captopril renography would reproduce functional evidence of impaired left renal perfusion without identifying the structural cause. In summary, the misdiagnosis is post-biopsy Page kidney. The decisive study must image the perirenal and subcapsular spaces rather than repeat standard renovascular testing. Non-contrast computed tomography directly connects the procedure, anemia, flank findings, renin excess, and abnormal intrarenal waveforms. Primary teaching point: Page kidney is renin-mediated hypertension caused by external renal compression, commonly from a subcapsular hematoma. Secondary teaching point: diagnostic failure occurs when testing focuses only on the renal artery lumen and fails to image the kidney capsule and surrounding tissues. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.